So today we're going to be talking about the ophthalmologic manifestations of shunt failure, and it can either be a shunt that's placed in a kid for hydrocephalus or a shunt that's placed in an adult either for hydrocephalus or for idiopathic intracranial hypertension, IIH, also known as pseudotumor cerebri. Shunts come in different flavors: ventriculoperitoneal shunt, ventriculoatrial shunt, lumboperitoneal shunt. At our hospital, we prefer stereotactically placed programmable valve ventriculoperitoneal shunts for our IIH patients. So a lot of our patients come to us and they're shunt dependent. And what that means is they require the shunt to keep their pressure in an acceptable range, even if the shunt is only partially functioning. And the way that shunt failure comes to us as ophthalmologists on the afferent side is with decreased vision. And that decreased vision can be with swollen optic nerve from increased intracranial pressure, papilledema, or it can be without a swollen nerve. It can just be a pale nerve. On the efferent side, it comes to us as diplopia, and that can be from a non-localizing sign of increased intracranial pressure, a cranial nerve 6 palsy. And so they're going to have an esotropia with an incomitant deviation that's worse in the gaze direction of the paretic muscle. It can be unilateral or bilateral. And the second efferent way this comes to us is the dorsal midbrain syndrome. So in patients who have dilation of the ventricle, the fourth ventricle, and the aqueduct of Sylvius, if we have a Sylvian aqueduct syndrome with compression of the outflow, we can get dilation of the aqueduct, and that will act like a mass pressing on the dorsal midbrain. And the dorsal midbrain syndrome, as you know, is characterized by lid retraction, convergence retraction nystagmus, especially on attempted upgaze, a vertical gaze palsy, usually for upgaze, and light near dissociation of the pupils. So if we have vision loss, papilledema, a cranial nerve 6 palsy, or the dorsal midbrain syndrome in a patient who has a shunt and is shunt dependent, we should be worried about shunt failure. So those are the ways that shunt failure comes to us. And we're going to be testing the integrity of this shunt, firstly with just a plain CT scan, because if the ventricles are bigger, ventriculomegaly, than they were before, then we know that we have worsening hydrocephalus and neurosurgery has to change or replace this shunt. We can also do a Shunt Series, which is just a series of x-rays that will show that the shunt is connected from the skull through the neck and down to the thorax and abdomen. That doesn't tell you that it's working, it just tells you it's hooked up. But if it's disconnected or the catheter is rolled up in the abdomen, then you know it's broken. And then we have nuclear medicine studies where we can inject labeled technetium radioisotope into the shunt itself. And if we see the radionucleotide appeared in the belly, then we know that the shunt is patent and it's at least partially functioning. But the only way to know what the pressure is to measure it, and that means having a spinal tap with an opening pressure. So if we're worried about shunt function, we're going to examine the patient, we're going to look for papilledema, the clinical efferent and afferent findings of vision loss in shunt failure patients. We're going to do a CAT scan to look for ventriculomegaly. We might do an MRI scan to look for transependymal flow. We might do the Shunt Series to make sure it's all connected, and the nuclear medicine study to make sure it's patent. But ultimately, you're going to have to measure the pressure with a lumbar puncture if you're worried if the shunt is working or not. And so an ophthalmologist's role is to check for the afferent and efferent findings to suggest shunt failure in any shunt-dependent patient who's presenting with new symptoms.